Hello, everyone. It's Dr. Jensen from Dean's Chat. If you're on the fence as to whether you want to join the American Podiatric Medical Association, jump on in. It's a new APMA. Whether it's advocacy concerns, scope of practice, billing and coding, consider membership at the APMA as your professional insurance.
Hello, everyone. Welcome back to Dean's Chat, where we discuss all things podiatric medicine. My name is Dr. Jeffrey Jensen. I'm the Dean at the Arizona College of Podiatric Medicine and co-host for the Dean's Chat podcast. Once again, I am joined by my co-host, Dr. Joanna Richey. Hi, Joe.
Hey, Jeff. How are you doing?
I'm doing pretty darn good. We had quite a morning today. We did a whole strategic planning meeting and kind of plotting the future of our college, and it was a lot of fun, I thought. What'd you think?
Oh, I completely agree. And I have to say, again, we're going to do a little gushing just for one brief moment. What I appreciate so much is the support, not just from the College of Podiatric Medicine, but as Midwestern University as a whole, in supporting us in this idea of innovative opportunities to teach our students and engage with them, and really bringing it into the forefront of what modern medical education is going to look like. And so I'm always pretty excited and energetic to come to work, but I'm equally enthused today as my brain is now like running in a million directions on some fun opportunities for the future.
Absolutely. Well, we have a phenomenal episode today.
Yes.
Long time coming, I might add. Dr. Dyane Tower, welcome to Dean's Chat.
Thank you so much for having me.
It's hard for me to call you Dr. Tower because we worked together. You came to the North Coloroado residency, which we'll give a more formal intro here in a couple minutes. But I will tell you, it has been nothing but truly an honor and a privilege and enjoyable watching your career flourish. So I look forward to talking with you.
I appreciate that. Thank you.
You're welcome. And it's okay. We go first names, Dyane, Joe, and Jeff.
Sounds good.
All right. Sounds good. Let me give you a little more formal introduction. Dyane is currently the Vice President of Clinical Affairs and the Medical Director for the American Podiatric Medical Association. She's been in that role, and this is hard for me to believe, almost 10 years now, Dyane. A little background history. Dyane got her undergraduate at Truman State in exercise science, hence the interest in physiology, biomechanics, and whatnot. Then you went on to get your DPM degree from the Rosalind Franklin University, Scholl College of Podiatric Medicine. You ended up getting a Master's of Science while you were there, Healthcare Administration and Management. So that might have been kind of the initial kind of pushing you into an administrative overview. Then you got your doctorate. Did I get that right? Oh, yeah, your doctorate came from there also. Oh, my gosh, you were all over it. All right, so you got your DPM, and then you joined us in Colorado at the North Colorado Medical Center, 3-year surgical training program. And interestingly enough, you got a master's in public health post-residency at the Dartmouth Institute of Health Policy and Clinical Practice. You aren't the first clinician who had gotten that. Joe, we've interviewed a couple of other guests on our show with them.
She was the first. So,
she was the first.
Yeah, Rachel Albright had mentioned that Dyane did it for, I think it was Rachel, that one of our guests had mentioned that they were not the first person to do it, that Dyane was.
Right.
And so again, I was super excited to pick her brain about that.
I shouldn't have said you weren't the first. You weren't the only. That was the term I was looking for.
Yeah.
All right.
Yeah.
Well, we got a lot to talk about today, Dyane. Let's start off with your current role at APMA. We've had such exciting times in our profession. Over the years, I mean, if you look at it in terms of decades, you really appreciate the progression that our profession's made. But the last couple of years have been really interesting, especially from the political advocacy side at the APMA. Tell us about your role. Tell us about what you oversee, what you do on a daily basis, and really where you see the biggest impact coming from your role as a medical director.
Sure. Yeah, I've been with APMA, gosh, can you believe it? 9 years now. Left clinical practice 9 years ago to come to APMA full time. And it's been a joy. I left clinical practice, was really worried about what my life might be like not being in clinic. And it was a big decision to make at the time, but I had always thought that I would be in this type of a role. I just didn't know I would do it so early in my career. So over those years, I've done a number of different things at APMA. In this role, I used to help more with the Young Physicians program, but that program has grown so much. We have an even bigger team working on our young physician programming. But right now in my role, I do a lot with our education. We're beginning to reimagine our education at APMA. I oversee and help with our journal, our peer-reviewed publication, JAPMA. And one of the biggest things that we've got going these last couple of years is our research and data analytics. You mentioned the advocacy that APMA does, and as the only organization in the profession that can lobby Congress, we do a lot of advocacy. And back even when I started at APMA, it's those anecdotal stories that you would take to the Hill, and the staffers and the congressional leaders, they would love those stories. They still love those stories, but now they ask for the data. They ask for the evidence to support our position or our stories that we're sharing. And while our patient stories, of course, are very meaningful for us to tell or for our patients to tell directly, they really want that evidence. They want the numbers associated with it. They want to know what peer-reviewed publications are out there. And that's something that we've been working a lot on over the last year or so. We have APMA has an advocacy agenda, so a shorter list of things that we're really pushing for. And as a result of that advocacy agenda, we actually have a research agenda now that is very much in support of our advocacy agenda. So when our advocacy agenda talks about, reimbursement policy or parity with our MD and DO colleagues, we have a research agenda that now is pointing us in the direction of creating peer-reviewed publications that can support the cost savings that podiatrists might have in the healthcare system, or the effectiveness that we have, especially when we're working alongside our MD and DO colleagues, let's say like vascular surgery or endocrinology, things like that.
Wow, I'm anticipating maybe a 2 episodes with Dr. Tower. How are we going to unpack all this, Joe? What comes to your mind initially?
Yeah. Oh, I love this so much because it's such a neat opportunity to see exactly as you highlighted, Jeff, how far the profession has really come. And to your point, Dyane, it's not just, hey, look at this great work that we're doing, but now the question is, show me how that great work saves the healthcare system dollars, essentially, right? If we were to boil it down to the essentials of really what they want to know. And we know that, but we do need data to support this if we're going to continue to advocate for our profession. So I love that the APMA has really aligned that recognition, not just in advocating on our behalf, but also recognizing where those needs are. And we talked a little bit with Dr. Albright about some of these things too. When you went through the APMA fellowship, public health degree program, can you talk a little bit about how did that framework help you start to look at these issues with that kind of a lens of how do we answer these questions? How do you show, Jeff and I were talking about this over the weekend, a positive intervention, you don't get to see all the negative consequences because hopefully you stopped the bleeding, right? How do you design for that?
Yeah, well, being at the Dartmouth Institute was just being able to learn from the people who are doing that kind of research. It was just a phenomenal experience. There had been a few other people in our profession who had gone through that program. Jim Roble and Jim DiResta both did master's degrees at the Dartmouth Institute, and they're the ones who really pushed for APMA to start that program, the APMA Public Health Fellowship, in partnership with the Dartmouth Institute. And so while I was the first fellow to go through and represent APMA or our profession in that way, there have been many others who have come after me, and each person has their own maybe area of focus or topics that they're the most interested in. But you go in with those ideas, and then you're kind of put into this framework. There's a whole course on how to do a systematic review and meta-analysis. So we each may have came in with our own topic idea that was of interest, but you follow the same recipe, if you will, throughout the courses to learn how to do systematic reviews. We learned how to do cost effectiveness analyses. We learned how to do linear and logistic regressions. And you just come to those classes with ideas for topics, and each person in the room is doing, there's an orthopedic surgeon in my class, there was a vascular surgeon in my class, there were endocrinology fellows in my class. And we each came with our own ideas, but then you just put it through that process, and it's, find the literature this week, and next week you're doing risk of bias tools, and then the next week you're, creating your models. So it was very interesting way of going about and learning what these other professionals, what the topics are that were of interest to them. But I will say one of the most interesting parts of that program was a class that you take that's all about the healthcare system. And, Jeff, you mentioned I did this right after my residency, and I got there, and throughout that whole class, I was like, boy, this is really great information. I wish I knew how the healthcare system worked before I was a resident, because some of that information just was so helpful, things that I just never really understood or, grasped at that point in my career. And so it was a lot about like how the system works, and how to look at outcomes and how to look at cost. And Joe, to your point, we talk about this now in one of the groups that I'm working with on an episode-based cost measure. If you look at things, let's say over a 90-day period, and you do it all right in the first 90 days, you're hoping that there are some cost savings that you're going to get. But if you don't track these measures long enough, they just look like you spent a lot of money and not seeing any of those costs. And so, those are some of the things that we talked about when I was at the Dartmouth Institute that I'm putting into practice now as I'm working on, development of a cost measure with CMS, the Centers for Medicare and Medicaid Services.
Oh man, so much. I'm gonna let the ball go back to Jeff, because these are the big puzzle pieces that if we can get these to line up properly, again, when we go out and do the great work that podiatrists across the country are doing, it's one thing to do it. It's another one to really represent to the healthcare system, which is who, unfortunately, we work for, whether we like it or not, to show that value in meaningful ways. And maybe it's cost savings, maybe it's health quality metrics. Again, there's lots of different ways we can put parameters on it, but I appreciate that very much. And I'd love we can take this as a sidebar, like go through as you said, Jeff, maybe in a whole nother episode, like how does the healthcare system work? I would love to know myself, but I'll throw it back to you, Jeff.
Thank you, Joe. Diane, all these things started going through my mind, like value-based medicine. All the NIH work we used to do in Colorado stemmed around the NIH telling us they wanted three things if they were going to fund research. They wanted a huge problem, they wanted a benefit that is up until now not seen by the patients, and they wanted to save money. Talk about the trifecta, right? I mean, we were talking about that, but we weren't quantifying it back then. Diane, when did you start hearing about value-based medicine or quantifying results? And when did podiatry first start getting involved? I'm just trying to get a little framework here.
Yeah, that's a good question. I don't know that I have the answers to it, but I mean, we started talking about this a lot, the value-based care, when I was at the Dartmouth Institute. I hadn't really thought of it much before then, or really heard much of it. Residency's busy in a community health system, not in a big academic institution where maybe there was as much talk of, at that time, even like accountable care organizations or, moving into that value-based system. So I really started hearing more about it and learning more about it when I was at the Dartmouth Institute. The folks who really created that first accountable care organization were from Dartmouth. So there was a lot of talk about that in the program that I went through. And, as far as, when our profession got involved or is participating in that, I would say my understanding of all of it, being new to that, just about, I don't know, was it 15 years ago or so? We're getting more and more into it. There's an ACO that's got podiatry that's a big part of it right now. And we're talking a lot more about it with the federal programs. Of course, the APMA supports or provides resources for our members as they're going through, participating in some of these federal programs that are part of the value-based system. And now we're even, beginning to think about bundled payments and what that might look like someday. For fear that if they come to us and someday and say, and this is your bundled payment for this condition, if we don't have the data or the research to support a different number, a different reimbursement amount, I don't want us to have to say, okay, we'll take that amount. We want to make sure that we have those numbers ready to go and say, no, it actually costs this much, and we should spend this much because here are the outcomes. Here are the outcomes for these people to have great quality of life and, continue to work and contribute to their society and, their social standing.
And who would have ever thought 15 years ago that an accountable care organization such as Upperline, putting podiatry out first and foremost with their high-risk patients they see every day as a method to control disease states. Who would have ever thought that would occur? I'm proud of the profession and really excited about it going forward. Joe, your thoughts?
So it's interesting, actually. I was raised in an accountable care organization, and then I worked in it for my first career position. So I have kind of always grown up with that lens. Show me the value that you provide. We didn't work on RVUs or any of that, and the idea of working in an integrated system. I mean, that was the whole big sell on the benefit to the patient, right? And I think there are so many valuable pieces to that that I might just leave it at that. There are certainly areas that still have lots of opportunity for improvement. As Dyane said, when someone else tells you your value, it's very hard to change their mind without data. So being able to put that cart a little ahead of the horse so that hey, look, I'm going to plan strategically with a vision of this might be where it goes. So I want to be prepared to have an answer to that. I think that that's highly valuable. And I appreciate that APMA's leadership is already factoring that into some of their discussion points, because I think there's a lot to be said for pros with a value-based care, but I think there's also a lot of cautions that we want to be aware of so that we can mitigate them as necessary.
Well said. Dyane, I have a question for you. Where's the intersection between being a medical director, advocacy, and then the association leadership? Because it all kind of comes together and you're wearing all those hats, but would you have imagined those hats coming together? And how do they come together exactly?
Yeah, I guess they do come together. Yeah, I mean it's been a journey, it's been different parts of my experience coming into play at different parts of my time at APMA in particular, first starting out at APMA, I was still considered a young physician, and I was helping with the young physician programming at that time, and then really grew into the more clinical affairs type of role, doing more of our practice survey and our the research side of things. Did a lot with our population health committee for a number of years, and just as things have grown at APMA, as we've shifted focus, looking at the education side of things and incorporating, our population health efforts, our diversity, equity, and inclusion efforts over the years, our clinical education, and really just it's been somewhat of a path that's brought it all together. And then about 5 years into my time at APMA, I started working with some coaches and mentors that are outside of the profession, but much more in the leadership development and association world. And they introduced me to the association management side of things. And there was so much to learn on that front. I came up from the clinical side, doing the clinical work, spoke at meetings, participated in education. So it's kind of like coming up through those ranks. But then there's this whole other side of the profession of the association profession that I'm now in. And I'm a curious person, love learning things, love being part of those academic circles. And then I got a chance to learn all of these other aspects, how to raise money for the association, doing things with development and sponsorships, learning more about membership, learning more about how to communicate and market things. So really just focusing on that part for a little while so that I could develop that side of my professional brain. And it's been a journey on that side too. And it's been really great because now in my current role, as an executive staff member at APMA, I get to see all of that in motion. I get to weigh in on all of that. And, I'm a unique staffer at APMA right now. I'm the only APMA member who's also a staff person at APMA. So, I love this profession. I love being able to be on the staff side to support you all, my colleagues, my friends across this country, and just learning those association aspects. I'm glad to have gone through that process so that I can help in a little bit different way and not just on the clinical side.
That was really evidenced when you were kind of spearheading the task force on education, residency training,
Yeah.
national boards. I mean, it went on, and that was a major effort. I think, correct me if I'm wrong, Diane, but I was part of that group, but didn't we work on that over about 6 months? And you were spearheading it, and you did a fabulous job. Not easy.
Not easy. A lot of complicated topics and complicated questions that we need to answer as a profession. Looking at podiatric medical education, residency training, testing, so licensure testing and fellowships. And it was about the last 6 months, a couple hours every month for calls and just trying to learn all of that with everyone on the call and share as much as we can so that the group can make as informed decisions as possible.
And informed decisions into the future are always challenging also. But anyways, I thought it was fabulous, and I thought you did a phenomenal job. Herding the cats, maybe that's the term I need to say. I don't know, probably not professional, but that felt like it at times, I'm sure.
It was great. Thank you. Yeah, and thank you for participating. That's what we need.
It was wonderful.
Yeah.
Did you know APMA provides help with public health initiatives, such as fall prevention, opioid abuse prevention, and addressing health disparities?
Did you know the APMA provides over $400,000 in scholarships annually to students pursuing podiatric medicine, helping the next generation of foot and ankle specialists?
If you're serious about this profession, if you want to grow, to lead, to make a lasting impact, join APMA today.
I'd love to know what do you think are the biggest challenges right now in the educational space when it comes to all? You could maybe either pick one or however whichever one of those. I know there's obviously multi-facets to that question, but in some of the work that you've done, and I know certainly the work that you're continuing to do, what do you think right now is the biggest challenge that warrants the most attention?
Well, one of the biggest challenges that we have is, we want to meet people where they are, and we need to make sure we know where they are. And, is that people want to come in person and have that community, that networking? Is it people who are busy and want to stay at home and do these, education things live, or they're going to do them on demand asynchronously? It's really trying to figure out where everyone is. And you all know, we as a profession, we're just so vastly different. Some people are employed, some people are private practice, some people are early career, hustling, doing different things. Some people are end of career, part-time, and all of those people are in different places, and we're trying to create things that may at times only be one size fits all, and that doesn't fit everybody's needs at that given moment. So I think that's one of the biggest challenges right now is figuring out where everyone is and how they want to receive education in particular.
Yeah, that's a great answer.
Yeah, that is a great answer. And you're both working on an educational task force right now, right? For the APMA.
Yeah.
I haven't, and Diane, I don't think I've shared this with you, but it's interesting how the pandemic shaped things, right? I mean, if you look back to April 2020, at the university, we were offering three-way mechanisms of delivery of the education. It was either you showed up live with lots of barriers and masks, or you
Yeah.
watched it live online streaming, or you went back and did lecture capture so you could watch it after the fact and watch it at 1.5 or 2 times speed. It's amazing how that period of time impacted the future of probably all education and all professions, but it's very particular with medical education. There's no going back, is there? I mean, you're working on this, I get it, but Joe, what are your thoughts?
Oh yeah, the horse is out of the barn for sure.
That's my point.
There is no putting that toothpaste back in the tube. But I think Diane's point is that, and I love talking to APMA leadership because that's such a excellent answer for a very complicated issue. How do you design something that is valuable and personal when we have so many columns to cater to? And I don't know if, and exactly as you said, Diane, maybe one size fits all the way, Jeff, it maybe used to be delivered and was just accepted as, well, this is just what we do because it's just what we do. Now we have options that's not just how we do. So then the question is, well, what do we do? Like, how do we recreate this wheel? And I think that's also where the most exciting parts come. So I'd love to then transition my next question. I love asking, what do you think the challenging things are? What are the things that you're the most excited about in terms of things on the horizon for APMA? And it could be educational or it could be anything that right now really lights you up.
Yeah, I'll start with the education piece since we're there, because some of the things that we're thinking through now is even the length of time for different things. We're used to hour-long episodes of education because we get 1 credit hour for those, but really trying to think through the attention span and micro learning, or smaller pieces of education that can maybe go together. So say it's a journal club of sorts, and we're going to talk about a journal article, and that may only take us 10 minutes to talk through, but if you string enough of those together, you can get to the 30-minute half credit or the 60-minute hour mark. So really trying to think of ways that we can package things, education in particular, but package things a little bit differently so that it keeps the attention span and what things people are interested in, those hot topics, front and center, so that it's more digestible and just, I have 10 minutes before I have a case to scrub into. I'm going to listen to this and then I'll go on to the next one after I scrub that case.
I love that. And did you coin microlearning, or is that a term that's out there?
I did not.
Well, it's funny you mention that because that's huge in dermatology right now. They're talking about, cases and, you're waiting for your kids in line at the bus stop or after school, and you whip on this app real quick and you get a 10-minute little micro. I had not heard the term microlearning, but it felt like it. And so when you said that, I'm like, oh my gosh, yeah, that makes so much sense. That probably is the future. I can see that for sure.
Yeah.
And I think it's also one of those unique periods in time where the way that we consume content has also shifted. So it's not just COVID made things where we realize what's the value of in-person versus what can I actually get through a screen that's pretty similar or the same as what I was getting having to fly and be in person. But now we also have things like Instagram and TikTok and YouTube and Facebook where it's these small little snippets that people are scrolling through. They don't want a 1-hour lecture on, how to do X procedure or people's opinions of X procedure. They would much rather see, 3 condensed pictures of the procedure. But what I think sometimes can get lost there, and certainly I'll switch only now to early learners because that's much more my space right now. The things that happen between steps A and G are very important and valuable, but they're not captured in that 30-second video, right? And so they are having to fill in those gaps, or they don't recognize that there is a gap. And so And obviously this is different. As we said, this is a different learner than, somebody that's been in practice for 15 years. They don't need someone going through steps A, B, C, and D. Like they can skip to G just fine without any problems. And so figuring out how to meet people where they are, which I love that you said that, because we talk about that with our students regularly. And again, really get to this idea of customized content, and almost to the point where you can tailor it to people exactly and they can pick where they are. But then if they're like, you know what, actually, I feel like I'm missing something, maybe they could go backwards a little bit and decompress it somewhat to fill in where those gaps are. And this is the stuff that, again, I just get really excited about, because we didn't have these opportunities, we'll say 20 years ago for sure, because I think Facebook came out when I was in college, but like Instagram and social media was 2012 or something. So this is very new still in the spectrum of how do we use this to its optimal advantages while not also losing the value that can sometimes get oversimplified. I'm curious what your thoughts are, Dyane, about oversimplification of some of these things.
Well, as you're talking about the different steps or being able to go back, I think back to residency time when, you might just an amputation or a hammer toe. Let's use a hammer toe, for example. You'd go in and one day you get to do the skin incision, right? And then you watch and you help and you retract and you assist the rest of the time. And then the next time you do it, maybe with the same attending, you're like, okay, I can do the skin incision. You do that, save time, but I want to do the tendon work, or I'm going to do the bone work today. And it's like you do one or you do some of each of those, but it may not be all strung in a row in the same case right away. So I'm doing like part A today. Next week I'll do part C. Next week I'll do part B. And then at some point in residency, miraculously, right, you leave and you're like, I know how to do all the steps of a hammer toe, even though you didn't do them all in a row the first time that you did them. And Joe, that's what I started thinking about when, you have maybe different parts of the education or curriculum that your students are like, they're really getting this part. It's like, well, we got to go back and fill in this part here. So, it's all part of, especially around professional education like this, or experiential education, where, you got to have a person who needs a hammer toe repaired in order to have that opportunity to be able to practice something like that. So that's what I start thinking about, is really just the different components of something that you do. It doesn't have to all be in the right order right away. It's just you pick up those things along the way and feel like you're really comfortable now with the bone cuts for this procedure. I need to work on my, dissection technique, and that's really what I'm going to focus on. And, just do those different parts of the procedures until you really feel like you get the hang of it.
Yeah, I like that.
Sounds like a great design for a training program, Dyane.
It really is.
That's great. I say that because we was our residency together, of course. So I have a question about the delivery and meeting people where they're at. We were talking recently about, and a shout out to Present and Alan Sherman and his team. Nothing's better than, you go to all these meetings during the year and you end up not going to the actual lectures because you've got a meeting for APMA, you've got a dinner meeting, it just all of a sudden you don't get your credits. And then on June 28th, you're logging in to present. Oh man, I need some credits. Let's go. And they're already canned for you, ready to go. So meeting people where they're at is absolutely crucial. I don't think that's going to change going forward, but I love the micro learning, and I love the fact that APMA is putting together a group to assess what is the best practices going forward. And I'm glad you're both on that task force.
Me too.
Can I ask you another question? Not unlike that. You had mentioned earlier doing systematic reviews and meta-analyses, and oh my gosh, the effort that goes into pulling articles and things. Now we've got AI. We have all these incredible resources at our fingertips. As we learned again today, Joe, we had an update. What do you think about that, Dyane? In terms of spearheading research or overseeing research, I could see you in your medical directorship role, having like 20 projects going on at once, because you could if you wanted to nowadays.
Yeah. We do have just about that many projects ongoing right now, although those are not being populated by AI. But yeah, it's an interesting question because we're doing a systematic review right now. We're using some special online programming. It's called Covidence. It's a special type of system that helps with organizing and being able to have multiple people review abstracts or titles or full papers to see if they meet your criteria. So, we're working through that. But it would be really interesting to see if and how AI could help go through those. We have our criteria that we've picked and put in the system to say, we're looking at open versus closed amputation sites. So we're trying to figure out what's better if you close it right away or if you leave it open. And we put those criteria in the system, and we use those as the people who are logging in, the humans who are logging in and seeing the criteria and saying, okay, does this title and abstract make it seem like we should read the full paper? Yes or no? But if we're putting all of that in the system, maybe the system could be doing those parts of the review because we've gone through thousands of papers, and it's very time consuming. It's a lot of work to go through a full proper systematic review and get data extracted from that for meta-analysis. So it's a very good question, and maybe we should be asking AI to help us with that.
Maybe, but I want to go back to Covidence for a minute. We had a tutorial on Covidence at the university level. Truly makes life a lot easier. For our audience, do you mind talking about Covidence for a few minutes and what it can do, what the learning curves are, and how it can literally change the time and energy to probably the most strenuous part of doing research?
Yeah, gosh, the figuring out your question that you want to add, your research question, and figuring out your criteria certainly is a big part of the project. It's the first most cumbersome hurdle to come up with all of the pieces of what you're trying to get to, what the question is that you're really trying to answer. But with Covidence, it's a special system. We're partnering with a library in Vermont, and it's currently housing all of the full text articles that we've picked and said that are going to be part of our paper. But before we got to that point, it's pulling based on our search terms, if it's open amputation, closed amputation, osteomyelitis, calcanectomy, we have all of these search words that we're pulling titles and abstracts at the very least. And then it's organized in like an online browser-based platform. And instead of back in the day, printing out the papers, reading the titles, putting a pile here, yes, a pile here, no. You're just reading through the titles and you say, oh, that title's talking about open amputation and it's comparing it to closed. That's really what we're looking for. Just check the box, yes, and it takes that one and puts it into the yes pile for you, and it just pops up the next title and abstract. And so you don't really have to worry about where the list of the titles is. It's keeping track of all of that for you. And then once you get done with that stage, title and abstract stage, it'll take you to the next stage. And that may be where you have all the full text articles. And we've been, again, partnering with University of Vermont. And so their research librarian has been helping us, and they helped us get the full text articles. And then we're going through, and this is where you have multiple people review and say it's the three of us. And, we need at least 2 people to say that this meets the criteria. And so Jeff, you and I might look at some of them, and you'd vote yes, I'd vote yes, it'd go in the yes pile. If we vote, you vote yes, I vote no, then we bring Joe in, and Joe gets to read it and say yes, this meets our criteria, or no. So it's so much more organized and just a very well thought out way to keep track of everything that you're doing with the meta-analysis or with the systematic review, to be able to then extract data for a meta-analysis.
It's a great overview.
And you have to give it a reason that you exclude it. And this was something we had talked about too. And that really helps with that flow chart then of just keeping track. Because to your point, Dyane, I used to have the students, I would tell them, you need to be meticulous on your spreadsheet. Why did you say this article was Why are we tossing it out? Because otherwise you go back and like, what exactly, why did you exclude 125 papers? Good luck. If you're like, uh-oh, that one was left blank, like you got to go find that one, look, read it through again and figure out why you excluded it. Because those are the metrics that as a reviewer for journals, and as you do as well for the Journal of American Podiatric Medicine, we want to know that information. We don't want you just to tell me, oh, we just got rid of, 90% of these. Well, that's fine, but why? Was this a biased exclusion or were these valid reasons to exclude them? So just keeping track of all of that is also just a massive time saver.
Yeah.
So fun. I'm very envious of today's students because they take all of this for granted and they don't remember the good old days when we were, waiting for articles to appear and then breaking out the red pen and, it's a different world we're living in. So I have a question for you, Dyane. Joe, we could do a little rapid fire, but Dyane, would you be willing to come back on the podcast so we can kind of go back and kind of walk through your career? Because I'm super interested in things, and I haven't even touched my question list because we've just been chatting, right?
We didn't know we talk education the whole time.
Right, exactly. But it's so incredible. And then there's so many things to talk about, and you really are involved in so many different aspects of our profession. I would like to extend an invitation back if you'd be willing to come back.
Yeah, absolutely. It'd be fabulous.
Right. That'd be great. That doesn't mean we can't do some rapid fire, though, Joe.
Yeah, and the fun kind of rapid fire.
Okay, you go first.
Okay, so one of my new favorite ones is if you could invite anyone to dinner from any time period, who would you ask and why? Could be famous or non, could be a personal family member, but who would you ask and why?
Oh, wow. Well, I did some family research and found out one of my ancestors fought in the battles of Lexington and Concord during the American Revolution. So I would like to meet that person.
Yeah. Wouldn't that be so tell me about your life. Like, tell me about the struggles and what it felt like to fight for freedom. I would want to sit and listen to that too.
Oh, that is incredible. So Dyane, you've lived in some big cities with lots of culinary, wonderful options. Which city have you lived in that has the best food?
Ooh. Oh, wow. I would say Chicago. We used to go to a sushi place in the city there, and I would say that's probably the best. The other places that we've lived have been a little bit farther from the big cities, so still some culinary, good culinary experiences in some of those smaller places. But yeah, I would say sushi in Chicago.
That's a common theme, Chicago, Joe. Whenever, people that have been in Chicago love Chicago. So, all right. And you answered what you would have. You'd have sushi. That's fabulous. Have you found great sushi places in DC? And it seems like whenever I go there, I eat sushi. So,
Well, that's interesting. I don't know that I've had much sushi in DC.
oh, all right.
I'll have to look next time I go.
Maybe I shouldn't be having sushi in DC.
Maybe you should give her some recommendations, Jeff.
There we
Like,
go.
you should go check
All
out
right.
these places.
Absolutely.
Yeah.
We'll do that. I'll send you some. All right. Your turn, Joe.
All right. Favorite place you've ever traveled and why?
Ooh. Well, we lived in New Hampshire and we loved it there. We so much so that after my fellowship, we ended up moving back. So I would say New Hampshire was a beautiful place and just loved New England atmosphere and would love to go back someday.
What do you remember from a social or fun perspective of residency in Colorado? What did you like to do in Colorado?
Oh, we went to Rocky Mountain National Park almost every weekend to hike and backcountry camp. So we were just about 40 minutes away from Rocky Mountain National Park, and we would get the annual pass to be in the park all the time. It was $20 back then. I don't know if it still is, but it was greatest investment. We got our own snowshoes and just did a lot of backcountry camping and hiking and snowshoeing while we were there.
That's the place to do it. It's fabulous. Well, very
All right.
good.
This one's going to be a two-part question. Best piece of advice you ever received and worst piece of advice that you've ever received.
Oh, wow. Oh, boy. Best piece of advice, don't take yourself too seriously. Boy. Worst piece of advice. Um, I don't know. See, I love the art of the reframe. This is what I love. This is what I try to do all the time, is even if there's something that doesn't work out the way you think it would or could or should, or you wish, there's always something positive in there. So
yeah.
This isn't necessarily a piece of advice, but when I took the job at Dartmouth, I wasn't really sure because I was teaching at Scholl at the time. Loved my job there, loved the students, loved the atmosphere. It's like going and being able to do surgery with your colleagues and peers, your help is right there if you need it. I hesitated in whether or not I should move to New Hampshire and take this job at Dartmouth. And back and forth many months with the chairperson of the department, who really was like, we're ready for a podiatrist. We want you to come. And it was months and months. And I was like, I'm just not really sure. So I ended up going. Clearly it didn't work out because I'm not there anymore. But not that that was a piece of advice, but I took that risk. Like, I went and I did it, but I wouldn't be where I am right now if I hadn't done it. And so it wasn't his advice to go and work at Dartmouth, but this chairperson recruited me very heavily for months, wanted me to come back because I'd met him while I was there in the program doing my MPH. And so like I was a known entity, they were very excited to have podiatry. And then that person wasn't the chairperson when I showed up 3 months later. And the vision wasn't there. The new person just didn't have the same vision for a podiatrist on that team like the first person did. And so it wasn't a piece of advice necessarily of you should come, but it's almost like a piece of advice. Go and do, and it didn't work out, but a lot of really great things happened because of my time there. And I certainly grew as a provider, as a clinician, as a surgeon, as a professional, as a person by going through that experience. So I like to think of the art of the reframe. If I think that there's been bad advice or I didn't do something that maybe I should have done in the way that I wanted to, but just trying to reframe that, make it more positive.
Oh, I love that. I'm a huge reframer. And there's an important distinction between reframing and toxic positivity, but maybe we'll save that for episode number 2 as well. Some of those lessons you have to learn the hard way.
I was going to say sometimes the best advice and the worst advice is the same advice. You never know.
This is why reframing is valuable, right?
That's right.
Like, what
Absolutely.
can I take from this and grow? And what part of this does not serve me? And I have permission to let it go.
I love that. Absolutely.
Yeah.
Well said, both of you. Thank you. Joe, any last thoughts before we close out part 1 of Dr. Dyane Tower?
Yeah. No, thank you so much, Dyane. This has just been so much fun, and it's been awesome to get to know you just a little bit over the last year or so, and I'm excited about what the future holds. So thank you for your time.
Thanks, Joe. Thanks, Jeff.
Thank you so much again, Dyane. And if you're listening on Apple or Spotify, please give us a 5-star rating. And if you're watching on YouTube, by all means, become a subscriber. Joe and I will continue to bring leaders in podiatric medicine. Dr. Tower, you certainly fit the bill. Thank you, and thank you for agreeing to come back on another episode. We also are, you're going to get 2 of these now. One for this episode and one for the next. So you'll have one at work, one at home. That way you can start your day the Dean's Chat way, no matter where you're at. So thanks again.
Great.
All right. Cheers, everybody. See you next week. Bye-bye now.
Bye-bye.